CNIB, Seeing Beyond Vision Loss. Seeing Things, Understanding Charles Bonnet Syndrome. CNIB Simcoe Muskoka Healthcare Professionals Breakfast and Senior Summit, October 21st, 2015. Dr. Keith Gordon, Vice President of Research, CNIB.
I've labeled my talk, "Thank goodness I'm not going crazy. I just have Charles Bonnet syndrome," and you'll see why as we go through it. Okay, to start with, let me define what we mean by Charles Bonnet syndrome. Charles Bonnet syndrome is very common. It is specifically due to sight loss. It's a complex hallucination, but it's not a hallucination that really bothers people. So it's not a mental health problem. It's not a hallucination that they interact with, and you'll see that as we go through today. And it's not a symptom of dementia or any other disease. And I understand there are a number of people here from long-term care facilities, and I think you're often straddling that line between people who are having hallucinations due to dementia and those that may be having hallucinations just due to Charles Bonnet syndrome, just due to the fact that they've lost vision. So when you have somebody who has some level of sight loss and they are experiencing hallucination, consider the fact that it might just be due to their sight loss and not due to dementia or other problems. Having said all of that, Charles Bonnet syndrome is not very well known, and it's not very well understood from a neurological and psychological point of view. And I hope that part of this journey that we're all on together will help elucidate and make things generally better known as to what Charles Bonnet is, and get people spurred to do some of the neurological research that's required. So again, to define what Charles Bonnet syndrome is, it's the experience of complex visual hallucinations, and neurologists and psychiatrists distinguish between simple visual hallucinations and complex visual hallucinations. Complex just means that there's a lot of things going on, a lot of people involved generally. It causes people who have lost some or all of their sight to see temporary visual hallucinations that don't last for very long, and things that aren't there. The symptoms of Charles Bonnet syndrome, they tend to begin in the months following loss of sight. They only affect sight. In other words, generally, people who have Charles Bonnet syndrome, unless they're losing their hearing at the same time, will not experience hallucinations in any of their other senses. There is an auditory form of Charles Bonnet syndrome, but we won't talk about that. It's called something else, and I can't remember at this time in the morning what it's called. But today we're talking about Charles Bonnet syndrome, which only affects sight loss. It can take many forms, and I'll give you some examples. They generally seem real to the person experiencing them, or surreal, and some of them are really quite dramatic and quite surrealistic. They're usually not scary to the individual, and I'll show you some research we've done that shows a wide range of emotions that people experience when they see them. They can appear at any time, and they can last from just a few seconds to several minutes, and they generally decrease in frequency over time. And although that was originally thought that within 18 months or so these would disappear, it's now known that a lot of people have it for a lot longer, and I'll get into that as well. I've already referred to the fact that people are usually aware that the hallucinations they're experiencing are not real. They see these things, they usually do represent real people or smaller people, but they know that they're not real, and they don't develop delusions. So the distinction between Charles Bonnet syndrome and other hallucinations generally is that people don't think that what they're seeing might hurt them. They don't get involved with the hallucinations. They know that it's not real. These aren't their friends. These are some things that they're seeing that are just out there. Okay, so let's go back to the beginning. Who was Charlie Bonnet, as I like to call him? He was a Swiss naturalist and philosopher, and he described the condition in 1760. Over 250 years ago, Charles Bonnet syndrome was first described. So why does it take 250 years for this awareness to spread? And I think we're all professionals working in this area just tend to be either relatively unaware of it or ignore it. I spent 30 years working for a company that made drugs and devices for ophthalmology, spent a lot of time with ophthalmologists and with their patients, and had never heard of Charles Bonnet syndrome until I came to CNIB. So, everybody is part of this lack of awareness, and I feel some sort of responsibility to turn that around, and this is the beginning of a journey. Charles Bonnet described this syndrome that he saw in his grandfather, who was blind due to cataracts. He knew that his grandfather was mentally sound, and yet his grandfather was seeing all sorts of things, patterns, figures, birds and buildings, that his grandfather knew were not there. He was fully aware that they weren't there. So Charles wrote it up in a scientific journal, and about 150 years later, the syndrome was named after him, and we are still floundering, trying to get a level of understanding in the world. I'd like to give you some examples of what some of these hallucinations sound like or seem like to the people that are experiencing them. These are real situations of people that I've talked to on the phone who call up and say they're really disturbed, they're having these hallucinations, can they talk to somebody? I'm not a psychotherapist or a therapist of any sort, but that somehow they get referred to me, and these are some of the stories I've heard. One woman was experiencing little men with umbrellas every night when she went to bed. These little men with umbrellas were on the end of her bed, and it was a consistent hallucination on her bed. Another man that I talked to had seen just about everything. It started with women in red dresses sweeping the floor in his living room. He had a brown pit bull with its tongue hanging out in his living room. One of the more bizarre ones, he had cloakroom tickets, the sort of tickets they give you when you check your coat at a theater, and they were lining the wall and the ceiling throughout his house. He'd grown up in England and done a bit of hiking, and he was aware of these ordnance survey maps. He had them all over his visual field. And the last time I talked to him, he called me a few times. He said, I woke up this morning, there was a bearded man in bed with me. So it's got to be a little disturbing. But, the third one was a little more disturbing. I said generally they're quite benign. But the third example was a woman I talked to who had grown up in Nazi Germany, and when she looked out the window of her house here, she was looking at soldiers marching down the street. So that must have been somewhat disturbing to her. Anyway, I just give those as examples because when you talk about hallucinations, people sort of like to understand what are people really seeing. Well, some of them are really bizarre. I mean, who would think you'd wake up in the morning and see, or go to bed at night and see little men with umbrellas in your bed? I mean, here are some examples of, these are slides were put together by Sherry Halsting, and I thank you for all your contributions to this. And she's got some examples here that she took from the Charles Bonnet Foundation in Australia. who gave examples of different eye diseases. Okay, Charles Bonnet syndrome comes from vision loss, not from specific eye diseases. Quite often it's associated with macular degeneration, and I think it's just because there are more people out there who lose sight due to macular degeneration than other conditions. Here's one from somebody with glaucoma, and the person said, "My walls are covered in these purple flowers. Even when I go outside, the lawns and pathways are a sea of these same purple flowers." Here's somebody with diabetic retinopathy, and this is what their visual field would look like. And the person said, "After lunch, when I sit in the living room, I often see miniature people moving from the right to the left. They wear strange outfits like the Oompa Loompas from the Willy Wonka Chocolate Factory film." I guess you'd have to know the Willy Wonka Chocolate Factory film to know what that means. And finally, here's somebody with age-related macular degeneration where the central visual field has gone. So that hole in the middle is due to the loss of central vision due to macular degeneration. And this person's seeing a cat. Everywhere I look, I see brickwork. Oh no, this person's seeing brickwork, not the cat. She's looking at a cat. When I look at my cat, its face is embedded in the bricks. So the brickwork is covering a whole visual field. And to go from that, I'd like to give you a real-life example. We had a patient with macular degeneration who was going to be coming here this morning, but unfortunately she had an accident yesterday and had to go to hospital. But she gave us a copy of what she would have said, and I'm going to ask Sherry if she would read it to you to give you an idea that this is a condition that affects real people in Canada, in Barrie. Thanks.
Okay, so I'm going to be giving you Brenda Brown's story, her thoughts. So, I have had problems with my eyesight from a very early age. I could see shapes and colors, but cannot read with my right eye. This was hard for me at first, but my left eye took over for both. Years later, my left eye began having problems. A small hole in my retina that was not in my field of vision, which was a good thing, but signs of macular changes were beginning. I can see things close to me, but not so much distance. I use a magnifying glass when needed, and people help me. I took a holiday with a friend to the sunny south to get away from Canada's snowy winter weather. I woke up early one morning and pulled the drapes open. I saw white villas, white fences, and the grass was covered with snow. It couldn't be, but that was what I saw. The temperature was in the 80 to 90 degree range. I woke my friend up and told her to come see the snow. Honoring me, she got up to see and told me that I was nuts and to go back to bed. The snow was gone by morning. She told me I better go see a shrink when we got back to Canada. It was so real to me, though. That was what I saw. The rest of the trip was great. I had no more strange sightings, but I did catch her looking puzzled at me a few times. After I got home, strange things started happening when I went to bed. I saw a tall man and a short lady looking at me from the hallway, standing with the glow of a nightlight behind them. After a few minutes of me watching them watching me, I got up and turned my light on. They were gone. The next night when I went to bed, I left my curtains open and the light off. I happened to look out, and there was a small dark bear and a small deer looking in my window. They were very cute and seemed friendly. I got up and closed my curtains, peeked out, and they were gone. I lay back in bed and questioned my sanity. I had seen a snow on a tropical island, a small, short lady and a tall man, a bear and a deer. Was I going crazy? I had been putting off visiting the CNIB in Barrie. I didn't think I was ready yet, but my sight was getting worse, and I was seeing things I knew could not be real. I made a call, and they were having a peer support meeting in 2 days. I had been isolating myself from family and friends and not getting out of the house for fear I might see something that wasn't really real. I didn't want people to think I was nuts. I was a bit hesitant at the first meeting, but it turned out to be the best thing I could do for myself. The staff was warm and friendly. I knew everyone at the meeting must have some form of sight problems. I really needed that meeting. I felt so comfortable, the information and the people were great. When the meeting was over, we were handed information on a presentation I had missed. The speaker had been Dr. Gordon, who had been researching CBS. When I got home, I read the information given to us about Charles Bonnet syndrome. I was totally jumping for joy. This paper could have been written about me almost word for word. It was like a huge weight lifted off my shoulders, written proof all my symptoms were real and I wasn't crazy or needing a psych assessment. I showed the info to my family doctor and his intern, and neither one knew anything about Charles Bonnet syndrome. He did ask me why I hadn't spoken of my hallucination to him. I said I was too scared that he might commit me. He took copies of my information and was glad I made him aware of the condition. As for my friend, I called her about CBS and told her I wasn't crazy. I gave her the information and she said she'd look it up to see if it even existed. She wasn't long calling me back and apologizing for not believing me. Thank you, Dr. Gordon, for your research and making my life better and making many others aware of these findings.
I think I can end the talk right here. Brenda Brown has said it all as far as I'm concerned. Thanks. Here's a slide I put together. It's just a sort of a melange, or whatever you want to call it, of art that have been done by artists who have experienced Charles Bonnet, just drawing things that they have seen. Distorted faces, eyes, music. Music is an interesting thing because people do hallucinate music, but usually if they try to play it, it makes no sense. So, and similarly, people do hallucinate words, and the words don't make any sense. Okay, so moving along to the more technical, there's no simple test to diagnose Charles Bonnet. Usually a doctor will try to rule out other conditions that could be causing the hallucinations, and there are many causes of hallucinations. I'm going to play you a talk by Dr. Oliver Sacks, the neurologist who passed away a couple of weeks ago. And he wrote a book on hallucinations, about 2 chapters of which are on Charles Bonnet. But he talks about all other forms of hallucinations, and by the time you finish the book, you're convinced that you must be hallucinating as well, because every possible condition can be associated with hallucinations. So what we tell our staff is that, yes, you need to reassure people that if they're losing vision loss, it's relatively normal. It's not atypical for people to be experiencing hallucinations, but it is important for them to go to their general practitioner, their family doctor, and have that family doctor refer them to a neurologist or a psychiatrist to make sure that there aren't any other causes behind those hallucinations. So Charles Bonnet is common for people losing sight, but there could be other causes of the hallucinations that have to be ruled out. So what treatment is there? We talked about diagnosis. Treatment is you need regular visits with your eye specialist to monitor your eye conditions. It's not really a treatment, but your surgical procedures or medical treatment for your eye condition could improve your vision and thereby minimize the Charles Bonnet syndrome. There are new medical treatments coming out every day. Our friends at Barrie have brought one out last year that is making a big difference to people with wet AMD. So it's important to keep going to your doctor, to your eye doctor, to your ophthalmologist. It's also important to keep updating your eyeglasses so that people do see somewhat, and if you have the sharpest vision possible, you can minimize the number of your risk of developing Charles Bonnet. It's not going to overcome it in most cases, but it is good to optimize your vision. It's also good to use magnifiers where possible to try and make sure that everything that you're seeing is as sharp as it can be. Now, some of these treatments here don't work for everybody. It works for some people, and it's worth trying. So they suggest you try changing some habits. If Charles Bonnet symptoms occur mostly when you're seated, try standing up. If the room is dimly lit, introduce lighting, or if it's brightly lit when you see the hallucinations, try dimming the lights. Blinking seems to work for some people. Rapid eye scanning, like starting on the left and going through the ceiling to the right, seems to work for some people. But people just need to try a lot of different things. It may work for some people, but there's no panacea. It's important to make sure that your healthcare professional, your family doctor, reviews all the medications being taken to make sure that some of the hallucinations are not due to the medication. And often sensory deprivation is a crucial factor in Charles Bonnet, so listening to the radio, watching television, anything that will stimulate the senses does seem to have some sort of an effect in minimizing the Charles Bonnet hallucinations. Okay, in terms of coping, we can all help Charles Bonnet sufferers. We heard from Brenda Brown that her friend reinforced the fact that she thought she was going nuts. So what we need to do is make sure that as friends of people or therapists of people who are experiencing hallucinations, that we listen to them, we assure them that it's not atypical to experience hallucinations and then you're not going nuts. We can share all sorts of information with them through help of people at CNIB here and CNIB in Toronto. We have developed a new pamphlet which is in your green folders there, and there are more available if you need them to distribute to people that you may be encountering. We have updated our website with a lot of the latest information on Charles Bonnet, and we've developed fact sheets which are also in here. Yeah, and that was again developed through the enthusiasm and encouragement of Sherry and Lucia here in CNIB Barrie. This is the center of the universe for Charles Bonnet syndrome. And okay, it's important to refer people to their family doctor. We talked about that. And we suggest that if you know one person with Charles Bonnet, you get them to talk to the client that you're dealing with who thinks they're going crazy. Reinforcement from friends who have experienced this is a major help to people in coping with Charles Bonnet. Okay, so I wanted to tell you a little bit about some of the research we've been doing. I'm an epidemiologist, not a therapist, not a psychiatrist or a neurologist, but epidemiologists look at statistics. So I wanted to know how many people coming into our doors at CNIB were experiencing Charles Bonnet. So we found the rationale behind some of the study was that there are very few studies that have been done on the prevalence of Charles Bonnet syndrome across all major eye diseases. You'll find some reports on glaucoma, some on macular degeneration, some on diabetic retinopathy, but never all of them in the same study. We have a very, very large client base, and that would enable us to do a comparison of all the major eye diseases in the same study. There are very few studies on the prevalence of Charles Bonnet in people undergoing vision rehab, so we wanted to understand who our clients are and whether they were typically experiencing Charles Bonnet syndrome. We also found that vision rehab professionals, our staff, were reluctant to discuss Charles Bonnet syndrome with people because they felt that they weren't psychiatrists and didn't have the ability to discuss that. Really, that to a certain extent that's true, but really what people are looking for is reinforcement, again, that they're not going crazy and that it is not atypical for people with sight loss to experience hallucinations. It's also been referred to several times. We also felt that we needed to understand it better because of the reluctance of people with vision loss to discuss their hallucinations. And then we wanted to publicize the whole aspect of Charles Bonnet amongst healthcare professionals like yourselves in order to overcome this lack of knowledge that is out in the general world and the healthcare world about Charles Bonnet syndrome. So we did this study on all new clients that were undergoing a low vision assessment at CNIB across the country, and we had our staff ask people this question. Many people who come to CNIB tell us that they see things they know are not there. Some see patterns or shapes, others see images of people or animals. Have you ever experienced this? And this question was used in a study done by Dr. Mary Lou Jackson at Harvard. So we felt if we used the same question, we could compare our results with hers. And that is, in fact, we found that we were more or less in the same level of prevalence in our clients as she had with hers. We then cross-tabulated the results of that question on the basis of age, gender, eye disease, visual acuity, or whether people lived alone or with others. And we had to do it statistically, so we did a multivariable logistic regression model, and I'm going to ask you all if you know what that is. Okay. Anyway, we had 2,500 responses, so it was a very, very big study. And we found that 18.8% of people in this large sample had experienced hallucinations. That's 1 in 5 people coming in our doors have experienced some level of hallucination. When you break it down by various subcategories, as I said, 18.8% of all subjects had it. Of the people over 81 years old, it was 20%. So it's more or less the same number. There was slightly more females. The level of the prevalence amongst females was slightly higher than amongst males. And I think that's just because men are too macho to admit that they're experiencing it. The near normal vision prevalence was lower, and I'll get into that in a minute. But the next thing I'd like to look at here is the AMD, glaucoma, and diabetic retinopathy were all more or less the same. And finally, we analyzed it as to whether people lived alone or didn't live alone. And the feeling was that my feeling was that if people lived alone, they would experience hallucinations more, just because there's no stimulus, less stimulus. It turned out exactly the opposite, and the explanation that I can give to it is that people who live alone don't want to admit that they're experiencing hallucinations because they're afraid they'll be committed. So I don't know that that is correct. And if you look at the literature, there are some studies that show that people who live alone have more hallucinations than those that don't, and others that show exactly the opposite. So that needs more research. When you do the statistics on it, you can see that if you look at I guess I got to stand behind the mic. The first group here shows that we did a comparison of people over 80 and people under 80 to see if there was a difference on the basis of age, and showed in fact there was no difference. The p-value here has got to be less than 0.05 to be significant statistically. There was no statistical difference. If you compared women and men, women were statistically did have a higher odds of developing hallucinations than men, and I think that's probably just due to this machismo in men. We did show that if you compare people with a low level of vision loss with those with higher level of vision loss, the people with a higher level of vision loss had a higher odds ratio. In other words, they had a greater chance of developing hallucinations than people with a low level of vision loss. So it seems to be directly dependent on the person's visual acuity. The better your visual acuity, the lower chance of developing hallucinations, but you can have hallucinations at all levels of vision loss. And then finally we compared here glaucoma with AMD and diabetic retinopathy in AMD and showed there was no difference. In other words, all three major eye diseases basically have the same chance of developing hallucinations. So it's not dependent on the disease itself, it's dependent on the vision loss and the level of vision loss. And finally, we discussed the not alone versus alone thing. It's more significant for people who don't live alone. So what do we conclude from this study is that 1 in 5 people coming to our organization are experiencing hallucinations. Hallucination prevalence is the same for all three major eye diseases. It's higher for people who live alone and lower for people with better vision. The most important thing for us as an organization is that we felt that our staff needed to know how to initiate the discussion. Most people just wanted to know that they're not going crazy. And the caveat which I've referred to before is that our staff need to know that they need to refer people to specialists just in case hallucinations are not due to Charles Bonnet. Okay, so that was the first study we did. That was just to see what the prevalence of these eye diseases are in our population, the prevalence of hallucinations are in our populations. Secondly, we wanted to gain a better understanding of what people are going through when they experience Charles Bonnet, what their friends were saying to them, how they reacted to what their friends said, what their eye doctors were saying, what their general practitioners were saying. So we conducted a structured interview with about 35 people who had answered yes to the question in the first study. 35 people who have experienced Charles Bonnet, and asked them a whole series of questions. We were designed to get the answers to the following questions. How do people feel when they're experiencing visual hallucinations? With whom did they discuss their experience of hallucinations? What types of reactions do people receive when they disclose their experiences? How do they feel when they find out their condition is related to their vision loss? How do people cope with their visual hallucinations? And what strategies or therapies do they feel would be helpful to people with Charles Bonnet? We did this through a structured interview by telephone. And here are our results. First of all, looking at the type and the frequency of hallucinations in this group. People experience a wide range of types of hallucinations, ranging from patterns through to animals and people. So not everybody sees people. Some people see patterns. I gave a talk in New Zealand. We'd done some of this work in New Zealand as well. And I gave a talk. A woman came up to me afterwards. She said, "I see these beautiful patterns." She said, "I really like it." so to each their own. Most people saw hallucinations almost every day. Most for just a few seconds or minutes at a time. So when we talk about hallucinations, you're not walking around in a world of hallucinations. You're seeing it for a few minutes at a time, often at the same time of the day, some people over the period of a day. Half the participants saw their hallucinations mostly at night, in darkness, or falling asleep. A third of participants didn't notice any pattern to their hallucinations, so pattern in terms of the time of day or darkness or light. A third of people found they could get rid of their hallucinations temporarily by blinking or moving their head. Other strategies were found that worked for people individually, so this blinking thing works for about a third of people. That's quite a lot. How do people react to their hallucinations? Experiencing a visual hallucination elicited a wide range of different emotional reactions, ranging from fear and confusion to indifference or even enjoyment. The fear wasn't usually fear of the hallucination itself, it's fear that you're losing it, that you're going crazy. But so it elicited this fear and confusion. Some people were indifferent, and as I say, somebody like the woman with patterns even enjoyed it. 2/3 of participants didn't find their hallucinations to be troublesome. Many participants thought that their hallucinations were somehow connected to mental illness and didn't want to tell their doctor about it for fear they'd be labeled as going crazy. Well, we knew that, but it's good to find that out in research because we can feed it back. We're in the process of writing this up for publication. 2/3 of participants spoke to an eye doctor about what they were experiencing. For half of the participants, their eye doctor was able to confirm their experience was not uncommon or nothing to worry about. Only 3 participants told the participant, only 3 eye doctors told the participant that their condition had a name. So people like to know that their condition has a name, you know. Tell them, hey, you got Charles Bonnet. Actually, when you listen to Oliver Sacks, he said, he talks about a patient, and he said the woman got so excited when she found out. She said, I have Charles Bonnet syndrome. so anyway, only 3 eye doctors told people that their condition had a name. A quarter of participants who spoke to their eye doctor had their hallucinations explained as a condition other than Charles Bonnet syndrome. One eye doctor response was, I think you're just dreaming. I want to say that again, a quarter of people who spoke to eye doctors were told that their hallucinations were due to something other than Charles Bonnet. I've talked to people who were told that one woman was told she had a migraine, another woman told the eye doctor she thought she was going crazy, and the doctor agreed. The doctor then, to his credit, sent her to a neurologist, but nevertheless, it's really important that eye doctors in general, and healthcare professionals in general, be aware of the condition so that they don't tell people, I think you're just dreaming. 3 participants mentioned speaking to a family doctor about their experiences. None of these family doctors provided any information to these individuals. Now, speaking to family and friends, 2/3 of participants spoke to family or friends about what they were experiencing. Almost half were met with a neutral reaction. A few participants had family or friends who joked about their hallucinations or laughed them off. Sounds like Brenda Brown. Almost a quarter of participants who disclosed their hallucinations to friends or family experienced negative reactions from others, such as being teased, having others feel uncomfortable, or being suspected of being mentally ill. Now, Grandma's losing it. Grandma ain't losing it, she's losing her vision. And how did you feel about reassurance that you received from others? For participants who did speak to someone about their hallucinations and learned that their experience was not uncommon, most felt comforted, reassured that they were not alone, or relieved they were not mentally ill. When participants were asked whether it would be useful to have previous awareness that the experience of visual hallucinations is not uncommon, about 1/3 of participants agreed this would be beneficial. I would have thought that would be much higher. To say 1/3 of people wanted to know and would have liked to know in advance that this could happen. I thought most people would want to know, but in this group it was only 1/3. When asked if it would be useful to speak to others who have experienced hallucinations, over half of participants felt this would be useful. in our experience through CNIB, we found that people do find that very useful. So that was our study, and just gives you some sort of a feel for what people are going through and some of the responses that they're getting from friends, families, and healthcare practitioners. We had the opportunity to put a question in the Canadian Retina Society is a group that represents all retina specialists in Canada. There are about 80 of them. These are people who treat macular degeneration, diabetic retinopathy primarily. They were doing a survey amongst their members, and we had the opportunity to put a question in their survey. And the question we put in was, when speaking with a patient with severe vision loss, do you discuss the possibility of the patient developing Charles Bonnet hallucinations? And we found that 56% of respondents said no. Okay, these retina specialists are treating folks every day who are losing vision. I talked to somebody last week who had done 75 injections that day, and that means 75 patients who are losing vision. If my statistics are correct, 1/5, what's 1/5 of 75? It's 15? 15 of that group, of that doctor's patient load that day, were probably going to experience Charles Bonnet syndrome, and they're not being told that this is a possibility. So I think we've got a real problem at the doctor level, and everywhere else in society for that matter. But this I found quite astounding. Okay, so that is my talk. I can't talk anywhere near as eloquently as Dr. Oliver Sacks. He was a famous neurologist, passed away a couple of weeks ago, and he's written all sorts of books, like the woman who thought her husband was the man who thought his wife was a hat. Anyway, he's written these very well-known books that I've read and can't remember, but I have read the Hallucinations book, and I do remember that, and I'd like you to listen to what he has to say.
The following is a presentation of TED Talks featuring Dr. Oliver Sacks. The program was recorded in February 2009 in Long Beach, California.
We see with the eyes, but we see with the brain as well. And seeing with the brain is often called imagination. And we are familiar with the landscapes of our own imagination, our inscapes. We've lived with them all our lives. But there are also hallucinations as well. And hallucinations are completely different. They don't seem to be of our creation. They don't seem to be under control. They seem to come from the outside and to mimic perception. So I'm going to be talking about hallucinations and a particular sort of visual hallucination which I see among my patients. A few months ago, I got a phone call from a nursing home where I work. They told me that one of their residents, an old lady in her 90s, was seeing things, and they wondered if she'd gone bonkers, or because she was an old lady, whether she'd had a stroke or whether she had Alzheimer's. And so they asked me if I would come and see Rosalie, the old lady. I went in to see her. It was evident straight away that she was perfectly sane and lucid and of good intelligence, but she'd been very startled and very bewildered because she'd been seeing things. And she told me, the nurses hadn't mentioned this, that she was blind, that she had been completely blind from macular degeneration for 5 years, but now, for the last few days, she'd been seeing things. So I said, what sort of things? And she said, people in Eastern dress, in drapes, walking up and down stairs. A man who turns towards me and smiles, but he has huge teeth on one side of his mouth. Animals, too. I see a white building, it's snowing, a soft snow. I see this horse with a harness dragging the snow away. Then one night, the scene changes. I see cats and dogs walking towards me. They come to a certain point and then stop. Then it changes again. I see a lot of children. They're walking up and down stairs. They wear bright colors, rose and blue, like Eastern dress. Sometimes, she said, before the people come on, she may hallucinate pink and blue squares on the floor, which seem to go up to the ceiling. So I said, is this like a dream? And she said, no, it's not like a dream, it's like a movie. She said it's got color, it's got motion, but it's completely silent, like a silent movie. And she said it's a rather boring movie. She said all these people with Eastern dress, walking up and down, very, very repetitive, very limited. And she had a sense of humor. She knew it was a hallucination, but she was frightened. She'd lived 95 years and she'd never had a hallucination before. She said that the hallucinations were unrelated to anything she was thinking or feeling or doing, that they seemed to come on by themselves or disappear. She had no control over them. She said she didn't recognize any of the people or places in the hallucinations, and none of the people or the animals, well, they all seemed oblivious of her. And she didn't know what was going on. She wondered if she was going mad or losing her mind. Well, I examined her carefully. She was a bright old lady, perfectly sane. She had no medical problems. She wasn't on any medications which could produce hallucinations, but she was blind. And I then said to her, I think I know what you have. I said there is a special form of visual hallucination which may go with deteriorating vision or blindness. This was originally described, I said, right back in the 18th century by a man called Charles Bonnet. And you have Charles Bonnet syndrome. There's nothing wrong with your brain, there's nothing wrong with your mind. You have Charles Bonnet syndrome. And she was very relieved at this, that there was nothing seriously the matter, and also rather curious. She said, who is this Charles Bonnet? She said, did he have them himself? And she said, tell all the nurses that I have Charles Bonnet syndrome. I'm not crazy, I'm not demented, I have Charles Bonnet syndrome. Well, so I did tell the nurses. Now, this for me is a common situation. I work in old age homes largely. I see a lot of elderly people who are hearing impaired or visually impaired. About 10% of the hearing impaired people get musical hallucinations. And about 10% of the visually impaired people get visual hallucinations. You don't have to be completely blind, only sufficiently impaired. Now, with the original description in the 18th century, Charles Bonnet did not have them. His grandfather had these hallucinations. His grandfather was a magistrate, an elderly man. He'd had cataract surgery. His vision was pretty poor. And in 1759, he described to his grandson various things he was seeing. The first thing he said was he saw a handkerchief in midair. It was a large blue handkerchief with 4 orange circles, and he knew it was a hallucination. You don't have handkerchiefs in midair. And then he saw a big wheel in midair. But sometimes he wasn't sure whether he was hallucinating or not, because the hallucinations would fit in the context of the visions. So on one occasion, when his granddaughters were visiting him, he said, and who are these handsome young men with you? And they said, alas, Grandpapa, there are no handsome young men. And then the handsome young men disappeared. It's typical of these hallucinations that they may come in a flash and disappear in a flash. They don't usually fade in and out. They're rather sudden, and they change suddenly. Charles Lulin, the grandfather, saw hundreds of different figures, different landscapes of all sorts. On one occasion, he saw a man in a bathrobe smoking a pipe and realized it was himself. That was the only figure he recognized. On one occasion, when he was walking the streets of Paris, he saw This was real, a scaffolding, but when he got back home, he saw a miniature of the scaffolding 6 inches high on his study table. This repetition of perception is sometimes called palinopsia. Well, with him and with Rosalie, what seems to be going on, and Rosalie said what's going on, and I said that as you lose vision, as the visual parts of the brain are no longer getting any input, they become hyperactive and excitable, and they start to fire spontaneously, and you start to see things. The things you see can be very complicated indeed. With another patient of mine who also had some vision, the vision she had could be disturbing. On one occasion, she said she saw a man in a striped shirt in a restaurant, and he turned round, and then he divided into 6 figures in striped shirts who started walking towards her, and then the 6 figures came together like a concertina. Once, when she was driving, or rather her husband was driving, the road divided into 4, and she felt herself going simultaneously up 4 roads. She had very mobile hallucinations as well. A lot of them had to do with a car. Sometimes she would see a teenage boy sitting on the hood of the car. He was very tenacious, and he moved rather gracefully when the car turned. And then when they came to a stop, the boy would do a sudden vertical takeoff 100 foot in the air and then disappear. Another patient of mine had a different sort of hallucination. This was a woman who didn't have trouble with her eyes, but the visual parts of her brain, a little tumor in the occipital cortex. And above all, she would see cartoons. And these cartoons would be transparent and would cover half the visual field, like a screen. And especially, she saw cartoons of Kermit the Frog. Now, I don't watch Sesame Street, but she made a point of saying, why Kermit? She said, Kermit the Frog means nothing to me. You know, I mean, I was wondering about Freudian determinants. Why Kermit? Kermit the Frog means nothing to me. She didn't mind the cartoons too much, but what did disturb her was she got very persistent images or hallucinations of faces. And as with Rosalie, the faces were often deformed with very large teeth or very large eyes. And these frightened her. Well, what is going on with these people? As a physician, I have to try and define what's going on and to reassure people, especially to reassure them that they're not going insane. Something like 10%, as I said, of visually impaired people get these, but no more than 1% of the people acknowledge them because they're afraid they will be seen as insane or something. And if they do mention them to their own doctors, they may be misdiagnosed. In particular, the notion is that if you see things or hear things, you're going mad. But the psychotic hallucinations are quite different. Psychotic hallucinations, whether they're visual or vocal, they address you, they accuse you, they seduce you, they humiliate you, they jeer at you. You interact with them. There is none of this quality of being addressed with these Charles Bonnet hallucinations. There is a film. You're seeing a film which had nothing to do with you, or that's how people think about it. There's also a rare thing called temporal lobe epilepsy, and sometimes if one has this, one may feel oneself transported back to a time and place in the past. You're at a particular road junction, you smell chestnuts roasting, you hear the traffic, all the senses are involved, and you're waiting for your girl. And it's that Tuesday evening back in 1982. The temporal lobe hallucinations are all sense hallucinations, full of feeling, full of familiarity, located in space and time, coherent, dramatic. The Charles Bonnet ones are quite different. So in the Charles Bonnet hallucinations, you have all sorts of level, from the geometrical hallucinations, the pink and blue squares the woman had, up to quite elaborate hallucinations with figures, and especially faces. Faces, and sometimes deformed faces, are the single commonest thing in these hallucinations. And one of the second commonest is cartoons. So what is going on? Fascinatingly, in the last few years, it's been possible to do functional brain imagery, to do fMRI on people as they are hallucinating. And in fact, to find that different parts of the visual brain are activated as they are hallucinating. When people have these simple geometrical hallucinations, the primary visual cortex is activated. This is the part of the brain which perceives edges and patterns. You don't form images with your primary visual cortex. When images are formed, a higher part of the visual cortex is involved in the temporal lobe. And in particular, one area of the temporal lobe is called the fusiform gyrus. And it's known that if people have damage in the fusiform gyrus, they may lose the ability to recognize faces. But if there's an abnormal activity in the fusiform gyrus, they may hallucinate faces. And this is exactly what you find in some of these people. There's an area in the anterior part of this gyrus where teeth and eyes are represented. And that part of the gyrus is activated when people get the deformed hallucinations. There is another part of the brain which is especially activated when one sees cartoons. It's activated when one recognizes cartoons, when one draws cartoons, or when one hallucinates them. It's very interesting that that should be specific. There are other parts of the brain which are specifically involved with the recognition and hallucination of buildings and landscapes. And around 1970, it was found that there were not only parts of the brain, but particular cells, face cells, were discovered around 1970. And now we know that there are hundreds of other sorts of cells, which can be very, very specific. So you may not only have car cells, you may have Aston Martin cells. I saw an Aston Martin this morning. I had to bring it in. and now it's in there somewhere. So now at this level, in what's called the infratemporal cortex, there are only visual images or figments or fragments. It's only at higher levels that the other senses join in and there are connections with memory and emotion. And in the Charles Bonnet syndrome, you don't go to those higher levels. You're in these levels of inferior visual cortex where you have thousands and tens of thousands and millions of images or figments or fragmentary figments, all neurally encoded in particular cells or small clusters of cells. Normally, these are all part of the integrated stream of perception or imagination, and one is not conscious of them. It is only if one is visually impaired or blind that the process is interrupted. And instead of getting normal perception, you are getting an anarchic, convulsive stimulation or release of all of these visual cells in the infratemporal cortex. So suddenly you see a face, suddenly you see a car, suddenly this, and suddenly that. The mind does its best to organize and to give some sort of coherence to this, but not terribly successfully. When these were first described, it was thought that they could be interpreted like dreams, but in fact people say, I don't recognize the people, I can't form any associations, Kermit means nothing to me. You don't get anywhere thinking of them as dreams. Well, I've more or less said what I wanted. I think I just want to recapitulate and say this is common. Think of the number of blind people. There must be hundreds of thousands of blind people who have these hallucinations but are too scared to mention them. So this sort of thing needs to be brought into notice for patients, for doctors, for the public. Finally, I think they are infinitely interesting and valuable for giving one some insight as to how the brain works. Charles Bonnet said 250 years ago, he wondered how, thinking of these hallucinations, how, as he put it, the theater of the mind could be generated by the machinery of the brain. Now, 250 years later, I think we're beginning to glimpse how this is done. Thanks very much.
That was superb. Thank you so much.
Okay, thank you.
You speak about these things with so much insight and empathy for your patients. I mean, have you yourself experienced any of the syndromes you write about?
I was afraid you would ask that. Yeah, a lot of them, and actually I'm a little visually impaired myself. I'm blind in one eye and not terribly good in the other, and I see the geometrical hallucinations, but they stop there.
And they don't disturb you? Because you understand what's doing it, it doesn't make you worry?
Well, they don't disturb me any more than my tinnitus. Which I ignore. They occasionally interest me. I have many pictures of them in my notebooks. I've gone and had an fMRI myself to see how my visual cortex is ticking over. And when I see all these hexagons and complex things, which I also have in visual migraine, I wonder whether everyone sees things like this and whether things like cave art or ornamental art may have been derived from them a bit.
That was an utterly, utterly fascinating talk. Thank you so much for sharing.
Okay.
Thank you.
Thank you. Thank you.
Dr. Sachs actually suffered from retinoblastoma, which is a tumor in the retina, and eventually spread to his body, and that's what eventually caused his death. So, anyway. I think he reinforced a lot of what we've been seeing and a lot of what I've been talking about. I just wanted you to understand how we're training our staff to make sure that that our clients and the staff and the referring doctors are all aware of it. Our staff need to refer the client to a family doctor. We are also making sure that people that are referred to the family doctor go out with a fact sheet on Charles Bonnet and now with his pamphlets, so that they can in turn train the doctors. So that when they say to the doctors, "Hey, I've got Charles Bonnet syndrome," the doctor says, "What's that?" You say, "Well, here it is, doc. Let me tell you about it." And we tell the client to tell the family doctor that the staff at CNIB feel that what I'm experiencing is due to my vision loss, but would like to have this confirmed by a medical specialist. Here is some information they've given me on this condition. We have a bunch of additional resources, and I think a lot of this is in your folders there. There are a couple of websites that are really good if you want to look at it. The Charles Bonnet Syndrome Foundation in Australia has a very good website. I've talked to the people there, and they're very committed to getting the word out and the latest research on Charles Bonnet. And RNIB has a fairly good representation on Charles Bonnet on their website. Before closing, I wanted to thank Barrie for their support of our research and their support of today's event and the development of this brochure. They are also going to be distributing that brochure to ophthalmologists and general practitioners across the country. So they are helping get the word out. We really could not do this without them, and I'd like to thank them very much. I'd also like to thank Lucia and Sherry and Marty for putting this event on and for really taking Charles Bonnet at least as seriously as I do. So thank you very much. It's essential that we build awareness. It's a long road we've undertaken, and I really feel that we're starting to convert the world and make sure that 250 years after Charles Bonnet, or Charlie as I call him, that people are aware of this syndrome. Thanks very much.
This event was made possible thanks to AMI Media Inc., Barrie, and the Ontario Trillium Foundation. CNIB Simcoe Muskoka is funded by United Way Greater Simcoe County and the North Simcoe Muskoka Local Health Integration Network. CNIB, Seeing Beyond Vision Loss.